So we're gonna do something a little bit different, where I think it's this is what goes in my brain when I think about progression, and I'm going to be jumping between trials and different thoughts, but this might explain why I think about progression the way I do, and might help see sort of how I treat the way I treat, and maybe a little bit put in context. Um, Trials that I think are going to come out in the next 6 to 12 months. There's going to be a ton of data coming out. And so this is going to be a preview maybe of what's coming in the next few months. Some of this was selected because I thought some of it would be out by now, and it hasn't quite happened. So it's a little bit more of a thought experiment maybe than anything else. So with that in mind, I continue to be a conflicted individual. We do most of the trials for a lot of the drugs, and so we participated in pretty much all the trials that I'll be talking about today. So we've talked a little bit about BTKs already. We talked about it at the last Ed Summit. But just to kind of recap a little bit of where we're at with this medicine, and maybe putting it in context a little bit. So there are at least 5 BTK inhibitors still getting looked at in MS. There are 3 of them already approved in the world of cancer. They've been looked at a lot in different rheumatological conditions, urticaria and things like this. One of them will probably get approved for that indication soon. For us, where it became interesting is that it might be sort of a 2-for drug. What I mean by that is this Bruton's tyrosine kinase is a part of the pathway that helps signal and send messages inside of a cell, and it links up in a pathway within B cells, which we talk a lot about. So you guys are probably a little bit more familiar with this. And we associate B cells a lot with sort of the inflammation part of MS and contrast enhancing lesions, active lesions, or T2 lesions, or relapses and things like this. Here it signals through the B cell receptor, and it's again kind of involved with this inflammatory activity. We thought there might be a helpful in progressive disease because they're also involved in the activation of microglia. And we'll talk a little bit more about the role of microglia. This is going to be a cell that we will be talking a lot about, I think, in the near future. So I'll just start planting the seed with this presentation some. And in microglia, instead of binding to the B cell receptor, it binds to this, which is a receptor that also kind of helps send as immune complexes form, that can bind this Fc gamma receptor and send signals in to again activate those microglia. The inhibitors basically inhibit that molecule, so you can't signal. And so again, it would have an effect on progression because of the microglia, and on the inflammatory activity because of the B cell effect. So that's the hope. That's kind of where we're going. We heard about evobrutinib earlier last year. It did not pan out for either. We did not see an effect on relapses or really an effect in progression in that trial. And then we presented and talked a little bit about tolebrutinib, which is kind of the second one that's coming out. And tolebrutinib might get approved in September. And why, we'll show in the next slides. To put it in context, later this winter, maybe early next year, we'll start hearing about the third one, which is fenebrutinib, with trials in progressive disease that will probably come out earlier, kind of towards the end of the year. One of the relapsing trials later this year, one early next year, is the latest gossip on the street. Remibrutinib, the fourth one, maybe in a year and a half, something like that. And then there's a third one that just started kind of its phase 3 trials from Biogen that's kind of up and coming as well. All right, so let's talk about where we're at with these trials. So Gemini 1 and 2 are the relapsing trials. And we can see that on relapses, it did not look very hot. So we kind of see very similar numbers. The number of of relapses in both trials were fairly low, but again, not really seeing a difference between them. So from a relapsing perspective, it did not look very promising. From an MRI perspective, in contrast enhancing lesions, we can see that patients with tolebrutinib actually had almost twice as many lesions as patients on teriflunomide or Aubagio. Teriflunomide being the generic name for Aubagio, the brand name. On T2 lesions, a trend to having more lesions, statistically maybe not a difference, but you can see that it looks kind of fairly similar in both trials, trending in the wrong direction as far as having an effect on that inflammation component to things. When we look at the Hercules trial, so this is the progressive trial, as far as MRI activity, this isn't compared against teriflunomide, it's compared against a placebo. And here we see that there was actually a non-significant, but a decrease in number of new T2 lesions. Did they not tell us what the contrast enhancing lesions look like? Probably fairly low because this is a progressive trial. But we would say that probably from an inflammation perspective, it's better than nothing, but it's worse than maybe teriflunomide, which we kind of put at the bottom tier of usually our 3 tiers of drugs. So a very small effect, if any, on relapsing activity and MRI lesions. All right, let's talk a little bit about progression. So we're going to go back and talk about the relapsing trials, those Gemini 1 and 2. And we see that as Dr. Gross talked about with confirmed disability progression, and here we'll talk about 6-month confirmed disability. They're starting to use worsening as opposed to progression. This is a trend that we're starting to see with trials. So you see these terms maybe interchangeably a lot. Worsening being a term that broadly incorporates progression plus life, all the other things that can happen to make you worse, such as getting older, twisting your ankle and not being able to walk as well might affect some of these scales and things like this. And because we have such a hard time telling the difference between what's MS and what isn't MS, it's a better term to use worsening than it is progression. So you're starting to see a trend, but think about them kind of being the same thing as far as kind of trial definitions go. And so we see in these trials that in spite of not really having an effect on inflammation, that we're seeing that there's a 29% reduction in that 6-month confirmed worsening. If we look at, go back and remind myself. If we look at the progressive trial or Hercules, we can see that that number jumps to a whopping 31% from 29%. So the effect is fairly similar as far as the reduction goes, telling us it's maybe doing kind of the same thing independent of whether a patient is a relapsing patient or a progressive patient. The one thing you'll see that's different, let me go back to the relapsing patient, is the number of events that you saw. So 10% versus 13%, so much lower numbers of patients actually having progression versus patients in a progressive trial where you would see sort of 27 versus 37% of patients having these endpoints of progression. Let's go back and look at Ocrevus, because that's the other drug that we have when we look at progressive disease and one of the drugs that we use a lot because of this trial. This was the Oratorio trial. The graph doesn't look as impressive because they had to put the 100% mark, and so everything kind of gets squished. But the number here is basically a 25% reduction. So you're talking about a 25% reduction in 6 months, 24% in 3 months versus that 29 versus 31%. So I would say it's in the ballpark, maybe if anything might be a little bit better. Now, does it help everybody in the trials? Let's explore that a little bit different. And how do the trials themselves compare? So at baseline, in the Ocrevus trial, in this trial, 28% of patients had an enhancing lesion at baseline versus only about 13% of patients had an enhancing lesion. So half as many patients had an enhancing lesion. Does this matter? Let's explore that a little bit further. So in the Ocrevus trial, we split the patients that had enhancing lesions and those that don't. This was the 3-month versus the 6-month. Again, very similar. It looks a little bit better because now we can not squished down at the bottom of the graph. But let's split it out into those that have enhancing lesions, where you saw a reduction of 35% versus a reduction in 16%. Again, you can look at 3 versus 6 months, and the numbers fairly similar between this. So it is a much better drug, Ocrevus is, if you have enhancing lesions than if you don't. We might argue whether that's primary progressive MS and all these other things, because we tend to think about enhancing lesions as being active lesions with relapses and things like this. But just to kind of say, patient selection is important, and this is part of the thought process when we're starting drug as to whether this is a good drug or not a good drug. Busy slide, I apologize for this, but this kind of breaks it further out. This is now looking at rituximab, another B-cell depleting therapy. This is the overall study. Here, the reduction was a 23% reduction in the 3-month confirmed disability progression, but we split it out by patients who are older versus younger and no enhancing lesions and those with enhancing lesions. So what does it look like here? So if you have enhancing lesions, so at baseline, there's 25% had enhancing lesions. Let's split it out by age. If you are older, your reduction was only 17%, 33% if you were younger. So overall, the 23% reduction. If you had contrast enhancing lesions, though, that reduction became 59% reduction with rituximab. So again, enhancing lesions look better. If you're younger, it looks better. If you're younger overall, you see a reduction of 48% and a whopping 67% if you have enhancing lesions and you're younger. So these are how we start to kind of say, hey, we take these numbers, they don't look very impressive, but it's because some patients are having an effect by the drug and some may not be having that much of an effect by the drug itself. Let's look at age a little bit more. So this is actually a bunch of you might be involved in this study. This was a study that involved 1,200 patients from here as they were starting drug. And we looked at sort of their disease activity by age. And we can see that there's a decrease by age overall in this study. So the inflammation kind of goes down with time. If we look at it by what type of drug you were on, we can see that patients on high efficacy drugs had much less disease activity, but there's still an age effect to this. If you were on really kind of more median type drugs, it was Tecfidera and Gilenya, that we saw that there was more disease activity, but there was probably a bigger age effect. And around the age of 54, as you could have seen in the prior slide that popped up a little bit early, the crossover point was about 54 years of age. So maybe not much of a difference in older patients between the drugs, but a big difference, much bigger than we would normally see for these studies if you have younger patients. So younger patients enhancing lesions matter. Who benefits from tolebrutinib? So we were thinking we would hear the same things, a breakdown by age, enhancing lesions. That came for naught at the last MS meeting, last 2 MS meetings now. So maybe to come at the next meetings. And I think it's going to skip that one and go straight till this fall before we really hear much more about tolebrutinib. I think they're busy putting stuff together for the FDA to get approved. But the one thing they presented was a little bit around pearls. Pearls sound very expensive and very fancy. We use them in MS to talk about lesions that show up on MRIs that have a paramagnetic rim lesion. That's a very fancy term to say around the outside of the lesion, there's a little bit of some magnetic signal. Basically, in this case, it tends to be iron. It tends to be picked up by cells of the immune system, macrophages and microglia. As they clean up things, they pick up some iron products. And you can see that there's you can see that there's dark signal kind of around the surface of the brain. But here's a lesion, and around the outside of that lesion, it's a dark rim around it. Inside the lesion, the little dot is a central vein. We talked a little bit about central veins becoming part of the criteria, the newer criteria. Pearls actually make it into the new criteria, or so we're being told. Hasn't been published yet. So more to come on that, I'm sure, at probably the next summits. Once they get fully publicized. But again, you can see here this rim around it. And again, it's this idea that there's microglia predominantly associated with these lesions. So these lesions have maybe more microglia. There's something different about them. As far as we understand them, these lesions start at the same time as new lesions start. It's just some lesions develop this rim and some lesions do not. But they've been associated with progressive disease. And I think sometimes, to me, that would imply that patients that are progressive would tend to have more of these lesions later in life as they become more progressive, and we wouldn't see them as much early on in a relapsing patient that's younger. Is that true? It turns out it is not. But they accumulate with more disability as well. Oops, I messed up. There we go. Perfect. I recovered. Nice. So in the tolebrutinib studies, again, this is the relapsing trial. This is the Hercules trial. What were the percentages of patients that had these pearls? And basically, both of them follow the rule of a third, with about a third of patients not having any pearls, about a third of them having 1 to 3 pearls, and about a third of patients having 4 or more pearls. So how do these different patients do? Drum roll, the excitement. So in the relapsing trial, we see that if you did not have any pearls, there really wasn't much of a difference in disability. If you have 1 to 3, you got a reduction of 46% and 49% if you had more than 4 pearls. So this suggests at least that in the relapsing population, that you had a big effect on disability accumulation if you have pearls. These pearls appear to happen very early, that we can see them in relapsing as much as we see them in progression. Let's go to the progressive trial. Tolebrutinib patients actually did a little bit worse, not statistically, but did a little bit worse if you had no pearls. With 1 pearl, there was a reduction in 15%. But if you had 4 or more, now you really saw a difference that was over 50%. Now, this is part of what we say, who will be a good person for tolebrutinib? It looks like if you have pearls, you might be a better candidate for tolebrutinib. And as far as what the effects of age, contrast-enhancing lesions, and all this other stuff, TBD. We'll have to figure it out because we've not heard that data yet. So hopefully this fall we'll get that data finally. With Ocrevus, it took until the FDA review came about because it took a while for the company to release that data. So sometimes there's ways to find out that it'll take us a while to kind of just filter out. The other thing to be concerned a little bit about is tolebrutinib does have some liver issues. We've seen this with some of the other BTK inhibitors, so it is something to be aware of. The suggestion and the gossip on the street is that it might require weekly labs for the first 3 months, if not 4 months. So we'll see kind of what this looks like. There was 1 death because of liver failure. 4 patients went on to actually have what they call DILI, which is basically drug-induced liver injury. And there's certain criteria that you have to meet. The important point is there was liver injury. If you caught it early, and the idea for this project of looking at labs frequently is that if you catch it early, stop the drug, the injury does reverse. And in the trials, they did not check it that frequently until later in the trial when we started to kind of see these signals for this. All right, so who else might benefit from these drugs? So I'm going to go back to actually an old study. So this is looking at the same trials that we talked about with Ocrevus, and we're going to talk about a lot of pharmacology. But basically, it's to look at big people versus little people. So it turns out that if you're bigger, you have more blood, you dilute out the drug more, so you get less drug per pound, if you think about it that way, since we give the same drug dose to everybody. So we split the groups into 4 by drug concentration. So group 4 had highest concentrations. There were the smaller people. There were more women in this group because they tend to be smaller. But you could see sort of their weights, how they went up into the bottom group that had the least amount of drug. We can see that the groups that had less drug concentration, it took them more infusions. So this is weeks. So think about 6 months, a year, 2 years to get to the point that you can play whack-a-mole and take care of those B cells. The third group kind of took a little bit longer. And if you were in the first kind of 2 smaller groups, for the most part, you kind of took care of your B cells pretty well by the time your next infusion kind of came around. So bigger people take longer to become B cell depleted. What's the effect on relapses in this group? So busy slide, but if you think about it, I think all the zeros speak for themselves. If you look at enhancing lesions in the top or T2 lesions in the bottom, if you look at the relapsing trials versus the progressive trials, you can see that basically if you were on Ocrevus, there was no MRI lesions. So really no difference in groups. If you look at relapse rates, a little bit of noise up and down, but overall pretty similar in the groups. So as far as efficacy on relapses, very little difference. But when you start to look at disability accumulation, this is kind of what led to the high dose studies, is that the group that was smallest is this line. The interferon line will always be at the top. The other groups kind of switch around a little bit, but small people did much, much, much better than people that were bigger. This is by drug concentration, by B cell levels. It looks about the same. It gets a little bit more squished, but here the reduction was about 66% reduction. So a much bigger difference that you saw in this group versus a 30% reduction or a 15% reduction if you were in this group. That was in the relapsing trial. If you look at the progressive trial, it looks very much the same with a reduction of 45% here compared to interferon. So again, if you were smaller, you tended to do better. So maybe more drug is better. Let's do a trial with more drug. We'll see about that in the next slide. This was looking at kind of the extended trial by if you had B cells or not. So just another marker of kind of drug levels. And we can see that with low level, if you depleted your B cells, you tended to do much better than on interferon. If you kind of at this point re-baseline and restarted, you can still see a separation of the curves. Twice as much disability if you still had B cells versus if you did not have B cells. So did high dose matter? The adverse events were very similar across group. In April 1st, so just a few weeks ago, we got the trials of the Musette trial and relapsing. The progressive trial is still to come out. This is just the complicated endpoint that they looked at, but basically I got a chance to take a sneak peek at this data. It'll get presented in a month at CMSC. There was really no difference by using high doses of Ocrevus as far as we could see so far. So more to come on this. So this is why we do studies. We create ideas, we test them out. Sometimes they pan out, sometimes they don't. So when people come in and asking about, hey, there was a small study with something, we need the big studies to really see if there's an effect from these drugs. I'm going to go through these really quick. This is a spinal fluid study to try and understand from a biomarker perspective a little bit better. So this is a study called the OBO study with ocrelizumab, but I think it provides a bit of tantalizing data. There were patients that got spinal taps kind of involved throughout their study, and they presented at the last set of meetings 5-year data on this. So we can see that B cell levels by the marker CD19 throughout time, so 3 months, 6 months, 1 year, 3 year, 5 year, that the reduction in B cells might be better after a year than they were early on, but it's an effect that we can see fairly early, even in the spinal fluid, even though Ocrevus does not make it into the spinal fluid. The reduction in neurofilament levels take a little bit longer, 6 months, but really better effect at a year and on. TREM2 is made by microglia, and just to highlight here, not much of a change until you get to year 3, year 5. So a bit of a delayed effect. microglia being made by microglia, TREM2 being made by microglia, which again is a marker of those pearls. So the effect by Ocrevus on microglia and those pearls might be delayed compared to maybe what we're seeing with the BTK inhibitors. So there's a lot of trials that are going to be coming out explaining some more of this. But this idea of maybe if we can get to those B cells in the spinal fluid, if BTKs are maybe not the answer, that's one of the exciting areas around CAR Ts, CAR NKs, stem cells. They might get into that a little bit better. There might be something called the brain shuttles, ways to get Ocrevus or other drugs into the spinal fluid a little bit better. What's the role in progressive disease of pearls in progressive disease? I think it's still to be decided. It'll be interesting to see what the effect is from Ocrevus. So a lot of studies being designed and thinking about that for that to come. A plug, you have this in front of you. It does take about 20 to 30 minutes to complete. It's a survey we're doing with psychiatry. If you have a few minutes, it's appreciated if you would complete it. And with that, I think we go to the Q&A. Awesome.